everyone to Neuroism. My name is Dr. Nick.
And my name is Dr. Lee.
In this video, we will illustrate a neurological case in about 5 minutes.
We are offering summaries and notes that are simple and easy to understand,
helping you to learn and boost your memories of the topic.
So let's get started now.
Somatic motor fibers origin within the facial nucleus in the caudal pons. It curves around the abducens nerve nucleus and exits the brainstem to enter the temporal bone via the internal auditory meatus. It passes through the internal auditory canal to give an innervation to stapedius muscle and leaves the skull via stylomastoid foramen to innervate the facial expression muscles and the platysma muscle.
The smaller component of the nerve, the nervus intermedius, contains a combination of autonomic, special sensory, taste, and general sensory fibers. Its preganglionic parasympathetic fibers arise from the superior salivatory nucleus, relay through the pterygopalatine to innervate the lacrimal gland for lacrimation, and via the chorda tympani nerve to the submandibular ganglion, to innervate the submandibular and sublingual glands for salivation. The remaining intermediate nerve fibers carry taste sensation from the anterior 2/3 of the tongue via the chorda tympani, and general somatic sensation from the external auditory canal and a small area behind the ear. Both fibers have their primary cell bodies in the geniculate ganglion, then ultimately terminate within the nucleus solitarius for taste sensation, and the spinal tract of the 5th cranial nerve for somatic sensation.
Bell's palsy. Bell's palsy was named after the Scottish anatomist Charles Bell. It is a self-limited, typically monophasic clinical syndrome of uncertain etiology, idiopathic. Typically, patients present with an acute, unilateral lower motor neuron paralysis of muscles innervated by the facial nerve that evolves over several hours to days.
About 1/2 of cases attain maximum paralysis in 48 hours and practically all within 3 or 4 days. It is also the most common cause of facial nerve injury and acute mononeuropathy.
The disorder affects men and women more or less equally, and occurs at all ages but is slightly more common in the 3rd to 5th decades. It also affects the right or left sides equally. The clinical manifestation of Bell's palsy consists of 1. Facial weakness in 60% of patients. The patients show inability to close the affected eye, logophthalmus, which risks the corneal being exposed and developing corneal erosion later on. The Bell phenomenon refers to the eyeball turning up without eyelid closure, despite attempted contraction of the orbicularis oculi muscle. 2. Impaired lacrimation in 60% of patients. 3. Impairment of taste sensation in 30 to 50% of patients. 4. Hyperacusis or distortion of sound in ipsilateral ear indicates paralysis of the stapedius muscle in about 15 to 30%. 5. Pain sensation behind the ear before the paralysis by a day or 2. 6. Synkinesis or aberrant regeneration is a faulty rewiring of the facial nerve that occurs after injury and recovery that produce unwanted contractions of the muscles of the face during attempted movement. For example, jaw winking is the closure of the ipsilateral eyelid when the jaw opens. Crocodile tears is the shedding of tears while eating or drinking in patients recovering from Bell palsy.
On the facial nerve examination, we can reveal a lower motor neuron paralysis of the innervated muscles. Clinicians may describe the degree of paralysis using the House-Brackman scale, where 1 is normal power and 6 is total paralysis. The treatment of Bell's palsy. In 2012, the American Academy of Neurology released guidelines stating that steroids are highly likely to be effective and increase the likelihood of recovery of facial nerve function in new-onset Bell palsy. Level A. The recommended dose of prednisone for the treatment of Bell palsy is 1 mg per kilogram or 60 mg per day for 6 days, followed by a taper, for a total of 10 days.
The American Academy of Neurology also suggested that antivirals, in addition to steroids, might be offered to increase the probability of recovery of facial function, level C. So if antiviral agents are used, they should be initiated in conjunction with corticosteroids. Acyclovir is administered at a dosage of 400 mg orally 5 times daily for 10 days. Valacyclovir is taken orally in doses of 500 mg twice daily for 5 days.
During the period of facial paralysis with incomplete eye closure, eye patching and artificial tears during the day and a lubricant eye gel at night are usually sufficient to prevent corneal abrasions.
There is insufficient evidence to suggest that surgical decompression of the facial nerve is effective.
Therefore, no recommendations for surgical decompression of the facial nerve are made. The overall prognosis is good. Most patients, 80 to 85%, recover completely, but the rest may have various residual effects.
The recovery rate from Bell palsy follows two patterns. Most patients begin to regain facial strength within 3 weeks after onset, but in some, the initiation of recovery is delayed for at least 3 to 6 months.
Well, that's complete our video about Bell's palsy.
And we hope this video can help you completely understand Bell's palsy.
If you like this kind of content, please kindly click on the like button.
Share this video with your friends.
And don't forget to subscribe to our channel. Ciao!